Is cortisone the answer to your foot and ankle issues? Cortisone is essentially an injectable anti-inflammatory medication, and it can have a significant number of benefits, but also risks. Some of the benefits of cortisone would be that it is injected into a local site of pathology. As a result, the patient typically does not require to take any systemic or oral anti-inflammatories or steroids. This can limit the issues associated with NSAIDs on the rest of the body, examples being reflux, or perhaps the patient has a history of gastric bleeding. There are a number of downsides to corticosteroid or cortisone injections. One example being that it actually does not lead to any tissue repair. So cortisone only works by dampening inflammation. It's an anti-inflammatory, it's an injectable anti-inflammatory. So some specific pathologies, if they're chronic enough, you tend to see absence of inflammation. What you see is increased scar tissue. Under a microscope, this would be known as a myxoid degenerative process. This tissue typically has poor vascularity and blood flow, and it's just very difficult for your body to heal. So if this process is not inflamed, how is an injectable or even oral anti-inflammatory going to help? My personal opinion is that it doesn't. Another potential risk of cortisone injections into the foot would be the effect or consequence of fat pad atrophy. So the fat pad protects the ball of the foot and the heel. So as an example, if a patient has been injected multiple times for a painful neuroma in the ball of the foot, sometimes you can see a loss of that fat pad and you lose the cushioning for the ball of the foot. And this is essentially bone on floor contact, which is quite uncomfortable and actually quite difficult to treat. I do tend to discourage corticosteroid injections for musculoskeletal issues, but there's one circumstance where I am a little bit more on board with offering them. This would be where there's an acute process or injury like acute plantar fasciitis, and the patient is actually inflamed. They're limping into the office and they're having difficulty with activities of daily living and they can't work. I think this is a good modality to offer because it is quite rapid onset from a relief standpoint. On the other hand, if the patient presents with more of a chronic process, like chronic plantar fasciitis, I'm more inclined to offer against a corticosteroid injection, but instead a more regenerative modality like shockwave therapy or a platelet-rich plasma injection.